Okay. Good afternoon, all. Welcome to CS Katha Varta. Today we have Dr. Vaanathi with us. She is an assistant professor at Department of Computational and Data Sciences at Indian Institute of Science, Bangalore. She is also the convener of Biomedical Image Analysis Biomedia Laboratory at CDS IISc. Prior to this, she was working as a postdoctoral research fellow at Athinola Martinos Center, Department of Radiology, Harvard Medical School, and Massachusetts General Hospital. She received her doctorate degree at Oxford Center for Function MRI of Brain, FMRIB, Wellcome Center of Integrative Neuroimaging, WIN, University of Oxford. She continued her research at WIN as a postdoctoral researcher, where she is currently affiliated as an honorary research fellow. She has around 10 years of experience in open source tool development for medical imaging applications. Uh, we welcome again Dr. Vaanathi, and the digital floor is yours. Please go ahead. Yeah.
Yeah, thanks, Professor Subankar. So today I'm going to talk about an important topic, especially when you use AI for healthcare systems. So I'm going to talk about artificial intelligence for biomarker extraction in medical images. So this is the overall the contents of my talk. First, I'm going to give an overview of how radiology workflow works, and then I'm going to also talk about the very broad level overview of medical imaging tasks using AI. And then I'll move on to AI applications in imaging for mainly vascular anomaly detection, just to give you an example of how we do detections in medical images, as you can think of these as use cases. And then finally, we will be looking at the challenges in AI tool development. So, for instance, the main thing we face is data or label limitations, and then moving on to how to make AI models more explainable or interpretable for clinical practices, and then domain adaptation methods, where we can minimize the shifts across different domains, how we can make the model robust across different domains. Right. So let's look at the radiology workflow, right? So there are vast amount of people involved in the overall radiology workflow, starting from radiographers and also people who design specific protocols to acquire images. So the image acquisition happens initially, so that has to happen for us to do the medical imaging task. So when you go for various checkups, doctors prescribe you scans, and you go to the radiology center and you get the scans done. So that's all part of the acquisition process. And then pre-processing, right? So a part of acquisition deals with how to improve the image quality, the protocol, designing for maintaining the image quality and everything. But even then, there might be some steps of pre-processing required to do the images better. And even if you have very good quality images, some amount of pre-processing might be required to make the images in the prescribed format and so on. So all these come under pre-processing, right? So any kind of analysis, any kind of processing, like masking or data cleanup that you do for further analysis, they all come under pre-processing. And then you have supposedly good quality images, and then we have these image based tasks. This is what I'm going to mainly focus on in this talk, and which would actually help me in reporting the different aspects of the image, right from their quality, their usability, and also the signs, the biomarkers or the lesions that are present in the image, the anomalies, and how to quantify them. So all that goes into the reporting, and finally which can be used for integrated diagnostic process. Now coming to the image based tasks, what can they entail, right? So there can be detection tasks which says, okay, so this image is normal coming from a healthy subject, this image has some abnormality, anomaly in it. So things like detecting where the lesions are in a very broad scale. And then characterization, so here you are pinpointing, you are going deeper, right? So you are essentially saying, okay, so there are actually lesions in this part, but then where exactly, what is the exact boundary of lesion, what is the extent of the lesion, So this can be used for further quantification as well, as in what is the area or volume of the total lesion that is present in the image, and then diagnosis. Given that these are the lesion characteristics, can we diagnose anything about the disease based on the lesion characteristics? Can we stage the disease, right? So what is the stage? Maybe it's in, for example, a very good example is diabetic retinopathy, where you can actually stage whether it's mild, moderate, or severe proliferative. So there are various stages. We will see one such example in the later part of this talk as well. And then finally comes monitoring. So the application of AI is very vast in medical imaging, right? So, and one of the main application, and which has actually quite a bit of untapped potential, is monitoring the progression of lesion over a period of time. So this can be specifically useful when you have when the patients undergo specific radiation therapy or chemotherapy, when we want to study how the tumor actually progresses over a period of time. Just an example, right? So these monitoring techniques can be extremely useful. Right. So now bucketing whatever we said in specific, um, categories, let's say. So applications of medical image analysis. So we can actually put one as diagnosis, which is segmenting the actual lesions or anomalies present in the image, and then their quantification and staging. The next is monitoring, as we said, the extent of the lesion over a period of time using longitudinal scans from the same patient, and also sometimes cross-sectional scans to specify at that given point of time how the lesion extent is. And then the treatment. So this is something that is essentially of very high utility in image guided therapies, where a doctor is or the surgeon is able to see a real world and real time feed from the image, the camera, where or like some kind of the device they put into the patient body while they are operating, and they are able to see the real time feedback while they are operating. It gives them better visibility, enhanced images, and also gives a better idea of where they are operating, right? Sometimes it's not always possible to see with very limited lighting what is happening. So the and AI can also add some details here, saying that some real-time segmentation, saying that okay, this nerve is going here, this blood vessel is going here, so maybe you don't want to touch this one, right? So these things are extremely useful when the surgeon is doing the surgery real time. And finally, one of the most commonly used utility of AI as of now is research study, right? So we want to know more about the particular tissue. So mostly used with histopathological modalities like microscopic images, like where we can get a bit more information of the tissue at microstructural level, right? So these kind of modalities can also be combined with macroscopic modalities, and they can actually give a very good idea of what the physiological and pathophysiological characteristics of that particular tissue is. Right. So where can they be useful? I spoke about diagnosis, but where it can be extremely useful is early diagnosis. It's also extremely challenging because the earlier the diagnosis is, that the lesions or the anomalies are probably very subtle and small in size. The challenge is to detect these subtle lesions so that the diseases can be detected early on some of the routine scans that the patient take. And these, when you find certain symptoms or signs on the scans, routine scans, we call those as incidental findings because you are not looking for them, right? So it's part of the routine scan, you just find them, right? This is where AI can be very useful. Let's say a healthy subject, a seemingly healthy subject, goes to get a scan, and they find some kind of early signs in their scan. That's the best time for them to refer to a clinician and get it sorted, right? At that point, even the disease might be reversible. So we are looking at early diagnosis. Differential diagnosis, this is the term commonly used among clinicians to define a very common symptom, which might be initial precursor for anything, right? So let's say that we have a headache. patient is reporting with headache, that could be due to stress, that could be because the patient has not eaten well, or that could also be because the patient actually has some internal disease inside, like some tumor is developing. It can be anything. It depends on the level of headache, and also it depends on what you see in the image, right? Now, that's why AI using medical imaging can be extremely useful for differential diagnosis. Screening and treatment planning, again, sort of like monitoring, but essentially here it's a longitudinal analysis. And one such example can be response to drug administration. So you administer the drug to the patient, you get longitudinal scans over a period of time, and you see how the lesion extent changes over a period of time. Monitoring and predictive analysis. So this could also be used in treatment. You see how the lesion is progressing pre and post surgery, for example, or any intervention, and you then detect, or you see how the disease severity has progressed, whether you have to change the intervention or can you put the patient under the same treatment, continue with the treatment. Data driven and hybrid decision making. So this can be useful when there are multiple factors, right? So when model is, or when a AI method is working on a specific task, it need not work on very similar task across domains, right? So for instance, if you say that there are two tumor lesions on liver, it's basically stage 4 metastasis or something, it might not be the same for let's say brain, right? So in brain it might be different. So you might have to sometimes put some domain knowledge in it, right? So the size of the lesion, the extent of the lesion, the contrast between the normal tissue and the lesion, that varies according to different domain, and some hybrid decision making process is required. And finally, the research, right? So to understand more about the disease condition. So now I'm going to give you a few use cases or some examples of what our group does for various applications, for various medical imaging applications, I would say, for diagnosis or for image synthesis and so on. So first we are going to see automated grading of diabetic retinopathy on optical coherence tomography ultrawide scans. So these are angiography scans, so they look like this, right? So they are of extremely high quality and high resolution. What I'm showing you here as a very small patch is actually somewhere around 2000 cross 2000 pixels, right? So they are very highly detailed. So the idea is essentially to get any vascular abnormalities that is present in this image. So diabetic retinopathy is divided into two stages, proliferative and non-proliferative. So any mild, moderate DR comes under non-proliferative stage, where the patient has not developed any vascular abnormality so far. Whereas in proliferative diabetic retinopathy, at this is the point where it gets irreversible, right? You cannot really treat it. You can moderate it, you can keep it under control, but the patient has very low success rate of becoming a normal, getting a normal retina back, right? The retinal vasculature starts to change. So what happens in the first one we are going to see is intraretinal microvascular abnormalities, shortly called IRMA. So what happens is the twisted blood vessels inside retina, they start looking like swollen capillaries, right? So that blood vessel starts to get twisted. Their structure changes, right? So what is the major challenge here? Depth information is required, which we don't have in the angiography. All we see is the scan. The tomography, so those things actually give the OCT B scans, which actually have the cross-sectional thing, right? So they actually they give a better idea about, IRMA, but this is all we have. That's a challenge. Non-perfusion area. So if you see, look at this green regions, right? So these regions are absolutely, um, empty, right? Sorry, the blue regions. Sorry. So if you look at these blue regions, they are actually quite black. They don't show any blood vessels, which means that the blood is not able to perfuse there. So there is a blockage sometimes, or there is a treatment that has resulted in it, or there is essentially some kind of DR related biomarker or some proliferation, lesion proliferation, which is preventing the blood flow there. But you see areas that lack perfusion, so they often occur with the abnormalities, IRMAs, so that these abnormalities can sometimes block the blood vessels. And then we have neovascularization. As the name suggests, this is formation of new abnormal blood vessels. It's a proliferative stage. At this point, diabetic retinopathy gets proliferative, right? You see a lot of these floral front-like patterns, which is not supposed to be here, right? The green area here, which is not supposed to be there. So that is what we say as NV. So now the idea is to detect these areas in the OCTA scans that we have got using artificial intelligence. There are various steps involved, right? The first step is quality assessment. So we did that as well, but I'm not going to focus on that. I'm going to mainly focus on the segmentation part only. So here we used a nested unit architecture, right? So the idea here is that we all know unit is a encoder decoder framework. So there is an encoder which essentially downsamples the features as they go, and then we have a bottleneck in the bottom, and then we have decoders which has a very good location information. So when we have downsample the image, we lose some of the texture information, but we still have location. So because the features get blurred out, we don't know how the texture is, but we can say where the lesion is, right? And when we upsample them consecutively in the decoder side, the location information is still preserved, but we want to combine the texture information that's lost as well. So that's why we have skip connections, which directly combines some of the features from encoder end to decoder end. So this is the normal unit architecture, but what happens in nested unit is that, so even in the path of skip connection, so there is a dense connection between various convolutional layers, right? So that the encoder and decoder backbone looks quite dense, right? So this nested architecture gives amazing, you know, versatility to the unit model to detect various sized lesions, and also can get the correlations between different structures very nicely, better than the normal unit, the vanilla unit model. So we use the log cos h function here, which involves a dice loss function. So DL stands for dice, which is the overlap between the actual lesion and the predicted lesion. Our idea here, our aim here is to maximize this overlap and minimize any false predictions. So we add that in the loss function. Our idea is to overall reduce the loss so that we actually put the DL in the log, so that the lower the value, so you actually get better segmentation. So these are some of our results. So here if you see, the magenta ones show the manual segmentations which are given to us by the clinicians to show how the IRMA regions are, and the green ones are what the model predicted based on the training. So we can see that there is a very good correlation between what the doctors have marked and what our model has predicted, which shows that the AI models with sufficient and good quality data will be able to detect the various abnormalities with high precision. So of course the non-perfusion areas are easy to detect comparatively than IRMA and NV. What I want to focus on in this last image is, if you see, it's a very small neovascularization area, and our model is able to get it quite clearly. So this shows the effect of loss function as well that we are using, and the nested unit architecture. The second use case I'm going to talk about. So far we saw the image of eye retina. So now we are going to see the image of brain, right? So what happens? How can we detect cerebral microbleeds on brain MR images? So microbleeds, as the name suggests, very small lesions, right? You can see these are the actual microbleeds, and these are some of the mimics that look like microbleeds. You can barely say the difference, which makes the whole task very challenging, and they are extremely difficult to detect because of this. And they are also early signs. They are also important to detect, because At this point, this is actually where a lot of neurodegenerative diseases like dementia, Alzheimer's, or any vascular, cerebrovascular diseases like stroke, ischemic attack, everything starts, right? So they can be a very good indicators for those. So detecting them can help us to put the patient in a very good treatment process. Another challenge, no location prior found so far. Brain is a very complex organ and it has lot of, you know, high frequency information going on, like lot of structures that are very complex in the brain. So detecting these small dots in such complex structures might be difficult. So having any prior would be useful actually. If there is any prior saying that okay, these lesions occur only in the cerebellum or only in the hippocampal region, that would be really useful, but we don't have such priors. These microbleeds can happen anywhere in the brain. So our first step here is to do a fast radial transform. So here we do a radial transform which basically detects any small, you can specify the radius in that, and it actually determines any small regions for a given small radius, and it detects all the candidates which have circular symmetry. So any circular regions, small circular objects will also be detected by FRST. Now we have got these candidates, but as you can see, it has some false detections as well. For example, this sulci is not a abnormality. It's supposed to be in the normal brain also. And similarly, in basal ganglial region, in sulci mainly, right? So you get a lot of false predictions. While our main idea is to keep the true predictions, true actual microbleeds, and remove the false predictions or the mimics that look like microbleeds, right? So that's why we devise another framework. So I'm very sorry for the busy slide. The slide has a lot of information here. So the idea here is essentially to distill the knowledge from a more complex network. We call it as teacher network. And then there is student network. So if you see the teacher network, you can usually train the network for multiple tasks and also using extensive data. And the model is also quite complex. Whereas if you look at the student network, you essentially use a very small model, often the subset of teacher model, and then you essentially do a very targeted task, right? So the idea is that student is essentially guided by the teacher using some loss function from the teacher model predictions, right? So here we have this teacher model which has three parts: the feature extractor part, the actual prediction part. Together they make the unit again, and then we have the domain discriminator, or you can actually say classification, patch level classifier, right? So now the idea is to segment, at the same time divide the brain into patches and detect the microbleeds in the patches. Why is it useful? It is useful because you are training the teacher to do two different tasks. So essentially, you are not only saying, okay, this is where the microbleeds is, you are also saying this patch, I think, might actually be more, it might have more chance to contain a microbleed. So there are two tasks that is happening, and this feature extractor you see in yellow box, it's being affected by both of these tasks. One is segmenter and another is classifier. So eventually what happens, maybe I can put a marker on it, laser pointer, yeah, right? So essentially what happens in the both the task is that because of these two tasks are divergent yet they have focus on microbleeds, the feature extractor is being affected by both, and they start learning the features that are very specific to microbleeds. Now, if you look at the student model, it basically has a subset of this architecture of the teacher model. It has only the feature extractor and the classifier. The idea is the candidates that come from the first stage, we want to discriminate the microbleeds from the mimics. So here we are able to do that, right? And there is a knowledge distillation loss which says that the softmax output of the student should be as close to teacher model as possible, right? So now we are not only detecting correctly, but we are also sort of, aligning it along with the teacher model's predictions, or the nature, the characteristics learned by the teacher model, which is essentially what the distillation does. Results, if you see, if you just use the student model without any distillation, you get the what is shown in the green plot, which is very low performance. And then let's say if only the teacher model, slightly better because it is more complex than student model. But then if you combine both, if you take the teacher model, you train it first and then you train the student model with guidance from the teacher model, then the performance is quite high. You get almost 90% recall, which is very good for such a small lesion like microbleeds. And also, if you look at the feature space, without knowledge distillation, the features are all merged out, right? The features, both the CMB, microbleed and non-microbleed features are all mingled. The model is not able to differentiate between microbleed and non-microbleed. But here, if you see, the orange ones are microbleeds, the blue ones are non-microbleeds, which has a very good delineation, like which has a very good separation between features, which is an excellent thing. Okay, so now we saw the couple of use cases. So what can you understand from there? There are a lot of challenges, but what are the main challenges that stand out? The first one are data and label limitations, right? So it's not often we walk into a clinic and we get the data. There are a lot of problems involved, right? So the clinicians might not be able to share, the patient privacy is there, right? So we might not be happy with our scans being shared. So applies to the clinical facility also. They won't be able to share. Sometimes you get data, but you don't get annotations. So data scarcity is a real problem in medical imaging, right? And also manual annotations. So let's say that you give them 100 of these in brain images and ask them to mark the exact tumor region. It's a very time consuming task because it's not just the slice alone. It's essentially brain MR is a 3D volume, right? Not only brain, even in just a retinal scan, on even if on just a photo, right? You give them and you ask them to mark something, it's a time taking process. So can we actually avoid the need for, or minimize the need for annotation, and use other methods like semi and self supervised methods, where you do not have manual segmentations, or you have it only partially, um, or in some other format, right? So how can we handle segmentation at that point, or even at this point can we say these are good quality images, bad quality images, these images are not supposed to be in here, using out of sample distribution. So they are of, like for instance, at image level you say that this has some abnormality, whereas these two are normal subjects, right? So they might be very useful for clinical applicability. For example, the next category is weak labels, where we have a weak supervision, like this the whole the region is a lesion, but the doctor has marked only these are all limitations. So how can we overcome data limitation, right? So we are looking at the need for synthesizing some of the lesion data, abnormal data. So this work was developed by one of the students of my lab. So essentially, the idea is to not use any deep learning and get some lesion-like regions, which can be useful for training to basically increase the data quantity. So the first step is just we add some noise within a very localized area. So this is the area we choose. We just generate some ellipses, and we can generate any kind of shape using these ellipses. I'm generating small lesions here. And then we add this noise on top of these regions, and you superimpose, you put the lesion back, these regions back on the original image. And this is how the synthetic lesion data looks like, right? So just wanted to show how these lesions could look like, right? So the last column here, this shows the original image, actually acquired image, which has brain tumor in here and some white matter lesions in here. So this could lead to dementia. It can be found in normal healthy adults as well, but these are one of the main causes of dementia and neurodegeneration in general as well. And this is one of the um, main dis- disease sign for intermediate diabetic retinopathy. We call those as exudates. And then these regions, this dark region here you see in the liver, is essentially liver tumors. On this is on liver CT, and then this is a breast ultrasound scan where you can actually see some lesions here. These hypoechoic regions, these ones are essentially the tumor regions. Some of them could be benign, some of them could be malignant. So we have brain MRI, retinal fundus imaging, abdominal CT imaging, and then breast ultrasound imaging. So various modalities. And these are the instances we synthetically generated. These lesions we created. They are not actual lesions. So you can see that they are very similar to the original lesions in their characteristics, but they also show some kind of heterogeneity, right? So this is what we saw in the feature space. The orange ones are the real lesions, whereas the blue ones are simulated ones. So we can actually see that they overlap well. At the same time, they also are spread out well, which shows that there is a sufficient heterogeneity there. At the same time, they are not deviating very well from the real lesions. So they can be used for various tasks, including training various deep learning models for segmentation purposes. That's what we did. And then we actually did lesion simulation mainly for anomaly segmentation in low data regimes. And what did we do? This is using only, I think we had somewhere between 10 to 15 images only. And in some of the modalities, we didn't even have them. What we did is the fully supervised case, what you see as FSUP, is only the model is trained on the available fully annotated data only, which is, as I said, 10 to 15 scans or lesser. And in the essentially there are two aspects that we did. One is we essentially data augmented the synthetic scans. For example, 10 to 15 scans if we had, we actually augmented, we just synthesized some 100 to 200 scans and we augmented it. Now we have a full loaded data set which we used to train the model. That was one setting, and another setting is we trained it using fully supervised and then we fine tuned using the augmented data. Now, if you see always the data that uses the augmented, the synthesized data in some way provided better performance in all cases, right? So you can actually see in in here also the liver tumor and also in the retinal scans here you can see that they are getting better performance. So the yellow regions here show the true positives. Blue regions show the false negatives, which are the regions missed by the model, and the red ones shows false positives, which are incorrectly detected by the models, right? So you can see more yellow regions in the cases where synthetic data is used, especially data augmentation performed better, even better than the fine tuning case, which shows that synthetic data can be really powerful tools, or the means of training a better model when compared to the actual fully supervised methods where the data is very limited. Another thing to note here is also the uncertainty in the prediction. So here if you see this column, it actually shows how confident your model is predicting this particular region. If you see in the first case, there are a lot of the more whiter it is essentially more confident. The low intensity means it's not confident enough. So if you see these predictions here, so there is essentially the region is quite sharp, less uncertain. Whereas here, if you see the fully supervised case here, it's not at all certain. Whereas here it's extremely certain and it is also giving good results. Now we come to an important topic, which is essentially the explainability in medical imaging. Let's say that you are actually applying a model, getting some result, and showing the result to a clinician. Now, you have to show the results in the way that they would understand, right? So clinicians, they do not understand how deep learning models work. Frankly speaking, most of the deep learning models are black boxes. Even those who develop it do not understand it fully. We only know changing this parameter will change the results in certain way. We don't know why that happens. So, having an explainability or interpretability in medical imaging, given the more complex nature of deep learning, is of utmost importance. I'll give you a couple of examples, right? So, the first one is domain shift in the data. There are these two images come from two different data sets which are acquired from two using two different scanners. Let's say, for instance, only for example, like it's using some Siemens or GE scanner. This is using a Philips scanner. So now the image that is going to come out of these two scanners are going to be very different. And if your model is trained mainly using these images, it might not work well on these images, right? In that case, it has to be there has to be a better method, or there has to be domain adaptation techniques which will adapt the model to work well from this domain to this domain. But most importantly, how would you explain that there is a domain shift to a clinician? So one such method could be to plot, some histograms to show that, the shape of the histograms are not really same for both domains. So that could be something that would indicate that the data is coming from two different distributions. The second one is inconsistencies in manual annotations, right? So let's say that you ask 5 experts to mark a tumor region, right? In from my experience, I can tell you that all 5 experts will not mark the tumor region in the same way. Depends on the radiologist's experience, and also they even their level of tiredness, because the more tired you get, the more mistakes you tend to make, and their underlying philosophy, right? Somebody who would actually if there is an extent of tumor, some people would think that okay, anything that is doubtful I will mark as tumor. Some people would think that I will mark it as tumor only if I am sure about it, right? How defensive essentially you are towards annotating, that also determines how what is the extent of annotation. There is not right or wrong about it, but here we need a consensus from the clinician to train the model, right? So there is one such example that's shown here. So we are actually seeing that different colors indicate the drawings made by different experts, and they are not overlapping. Essentially, you can see that you can clearly see that this kind of input, if you give to the model is going to struggle, right? Especially to determine the boundary of the lesion. So where the lesion is present is fairly consistent. They have said, all of them have said the lesion is here. But what is the extent of the lesion, right? What is the boundary of the lesion? That's where the model is going to struggle. Why do we need it? If we have to accurately quantify, if we have to say this is the volume of lesion, we need the boundary of lesion, right? And that volume might even determine whether the patient is going to operate, the doctor is going to operate the patient or not. Maybe they say, okay, the volume is less, we don't operate, right? So there are complications. So this has to be provided in an explainable manner. We need to when the output is provided, how confident the model is in predicting boundaries. For example, in the previous case we showed, right, the uncertainty. So the confidence of the model should be, that's one way of showing how explainable, how good your model is. The second is interactable binary results. You give a chest x-ray and you say that okay, uh, this one is essentially, so without XA, you just give the output. You put a black box model, you show that okay, this person is normal, or this person has pneumonia. There is some water content in the thing, right? But what you tell to doctor is only whether this patient is normal or not. There is a water content or there is essentially some abnormality going on here that you are not giving, right? Once you give that information, for example, here there is something going wrong, and you are actually giving a heat map showing this is where potentially things are going wrong. So that kind of information is very explainable and also tells the clinician what they want to know, which is essentially where things are going wrong, right? Because they are trained to see things that way. Whereas the deep learning models give yes or no. two class classification, right? That's not really useful for the clinician. So giving a bit more information in an explainable manner is very important when these AI models are hoped to be implemented in the clinical situations. That's very important. So I would probably take a quick break here and ask if there are any questions so far.
Yeah, Dr. Vanti, if there are other questions, I will probably ask them to raise your hand. I have a quick one. How did you like verify like those legions that you added artificially are like correct? Is it just because of the distribution in the space? Like,
Yeah, so we also had Froch's inference distance, which is what we call as FID score. The more the score, essentially we calculate the score between the actual lesion, for example, this one and this one, let's say, and that score, the more they are, that's essentially the more deviating they are from, divergent they are from the actual lesion. So there is a certain threshold that we want to meet if there is essentially not much distribution thing. So that is also something that we did. And like essentially also how realistic it is depends on the task, right? So for some task you might want to go to a bit of an extreme, whereas in some task you might want to maintain that subtlety, right? So in
I
that
see.
case we also, yeah, we balanced between both the cases, quantitatively and also qualitatively. For instance, for in our case we wanted to get the segmentation, so we did something very fine tuned or very specific to that particular task. If you are going for quality assessment, the type of lesions you detect, you generate might be slightly different. That's why we also wanted two things. One thing is we verified, we evaluated using some downstream task, which is segmentation here. Another
Hmm.
way of evaluating is that quantitative FID distance score I was talking about.
I see. Okay. Okay. Thanks. Thanks.
Yeah.
Yeah.
Any other questions or can I proceed?
Yeah, I think we can go ahead. Yeah.
Okay, great. Okay, so the next important topic I'm going to talk about is domain adaptation and privacy protection. So I have mentioned domain adaptation in a couple of slides earlier, but then let's formally get introduced to the term, right? So when you take data from multiple sources, which is very essential for medical imaging, because uh, you need to have models that work on multiple sources, right? And also data is so scarce that you cannot be saying that, okay, I'm going to take data from one source only. Essentially, you know, whatever information you get, you cannot throw away. So when you get data from multiple sources, it's a very big question mark how you combine the data or how you make the model work on that, on both data sets. If you are going to combine the data in some way and make them more harmonized, we call them as data, we call that process as data harmonization. Or on the other hand, you make the model more robust. We don't want to combine data, we want to essentially maintain data in the different domains, but then we want the model to work well in all the domains. That is what we call as domain adaptation. So transfers the knowledge across domains by leveraging domain invariant features, by minimizing the domain shifts. There are a lot of methods to do it, right? It's a um, whole large area in itself. So there are supervised domain adaptation, unsupervised domain adaptation. Essentially, in supervised domain adaptation, you have labels from both training data and test data, right? So sorry, from both source domain and target domain. So when you have, or you can actually put together and you can train, for example, fine tuning is a type of domain adaptation where you train on source domain and then you fine tune on target domain. What happens in unsupervised domain adaptation is essentially you don't have labels from target domain. You use the inherent characteristics of the target domain and kind of try to minimize the shift between the two, the two domains. There are multiple ways to do it, but what I'm going to focus on today is something that is data privacy preserving, which we call as federated learning framework. It's not a new area per se. Like it has got a lot of attention over the past 4 or 5 years, I would say, but the concept itself is not new, right? The idea here is that the data sharing is a huge problem in medical imaging. The clinics are not all of them are really amenable to the fact that they can share data. So what happens is, in federated learning, there is no need for the clients or the clinics to share data. Each individual sources here, we call them as clients, and the data is preserved in the individual clients. And rather than sharing the data, accumulating the data and training a single model, what we do here is that we train the models in the individual clients, and then we aggregate the model parameters in the end of each training to a common model which is present in the server, common server, which what we call as a global model, right? So then the local servers which are present in the clients are involved in model training, and then the models are finally aggregated to a global model which is present in the centralized server. So now you can see there is no need for sharing data. Data can exist in the individual centers, and then the training happens over fixed number of rounds, or even like in some kind of federated learning frameworks, that is also personalized, the number of rounds. For example, if you have a good quality data, you might not need more number of rounds, so that client converges quicker, and then the other clients still train, right? And then the idea here is that the global model has more generalized version of the model, because that has aggregation of all the models from all the clients, whereas the local models are more personalized for that particular client, right? So there are also additional personalization techniques that are employed in the individual clients specifically before aggregation, where that model is specifically trained for that particular client, right? So, a very successful framework for data privacy preservation, not without its own challenges. It also has challenges, which is essentially the setting up this framework itself, right? So, imagine the headache if you have to put all the model to be shared, and there's basically the centralized server as well, and there is communication that has to happen, uplink and downlink, because there is a lot of download and upload that has to happen across the servers for updating the models and aggregating them. Synchronization, right? When if one of the server is down for one of the client, then the synchronization and aggregation might be a problem, because all the servers, all the other clients will be waiting for that server to be on, right? So those things are, there is implementation level challenges, there are conceptual challenges as well, right? So there are some attacks that can still be done on the privacy of data, because the model weights update to some extent is going to give an indicator of how the data characteristics are. So in a very twisted manner, if you think, there can be still some attack on the data privacy, which has been shown actually, adversarial attacks, where the malicious agents are able to adversarially change the characteristics of data, or basically attack the model and change its characteristics. So how do we preserve even more privacy, right? So we don't want to share the even the overall weights, but can we actually uh, make it even more condensed in a way, or can we actually simplify this whole process? So those are some of the challenges involved in the federated learning framework as well. So this is my last slide. I wanted to end with a few concepts related to what are the opportunities and future directions that we are looking at in medical images. So this is by no means a very exhaustive list, right? So I have put some things which I feel are of utmost importance. There are a lot of many other things which could be of importance as well. But these are the things that are gaining a lot of momentum in very recent years, which would supposed to be a very hot topics of research as well over the next few years, at least I would say, right? The first is interpretability and trust, explainability, right? So this is becoming increasingly important. I cannot emphasize how important it has become over a couple of years. because clinicians have now started asking questions, right? So we are asking them to use AI in their applications. Now they are asking back, how do I trust? How can you explain what is happening, right? So there are a few methods that I have shown here. So one is feature saliency, showing not only we touched upon this, not only what is happening, but where it is happening at a very high scale, and also why it is happening, right? And then the class probabilities, instead of saying that okay, this is belong to this class, it's normal, it's abnormal, instead of that, saying giving more of a grayscale understanding, even at voxel level or pixel level, right? Saying okay, this pixel belongs to 25 percentage background, it can be 35 percentage belonging to ventricle lining, or it can be a lesion pixel as well. Whereas if pixel is 100 percentage in the lesion, which is not in the boundary, you can say it's 100 percentage in the lesion, it's not in the boundary, right? And also example based explanations, this could be very useful in training healthcare workers, right? So in a place where there is no senior person to train them, an experienced person, some counterfactuals can be created to train them, both positive and negative examples, all generated by AI. Essentially, the idea is to keep clinicians in the loop. If you want to make a product for them, keep them in the loop, right? So that they can give the feedback and they can also understand what's going on. That will give a bit of credibility to the models. And out of distribution detection, right? So if you are training a model to detect among five classes, the model is very good in detecting among five classes. But now, if you apply it on a new data set which has a sixth class, the model doesn't know how to react. The model will still classify that sixth class among one of those five classes, which is not what we want. So, what we want to work on is an open world anomaly detection problem where we say that don't want this targeted anomaly. Detect any anomaly and then characterize it for me, whether it's in distribution or out of distribution, characterize any anomaly that is present. And if you have such a framework within the federated learning setup, that could be a veritable source of data mining of any kind of disease lesion that can be or any anomaly that can be present in the population pool, which can also be used for incidental findings. I think I explained what incidental finding is earlier. So, accurate extraction of underexplored biomarkers. This is another branch of clinical research which is always ongoing and it's always of importance, where you detect new lesions and characterize their pathophysiological characteristics in the overall, the broad scheme of the disease, right? So, how it is progressing, what kind of effect it is having, what are the collateral damages, all those things. So here I have shown the uncertainty estimation, where essentially if you detect a lesion, the interior part is quite certain, right? So uncertainty is low. Whereas the boundary is where the uncertainty is and also where the contrast is low. So this kind of uncertainty maps can be useful for clinician as well, and also to give a feedback to the model itself to see that okay, see here is where you have done mistake, so you can put more weights in these regions and detect them properly, right? So that can also happen. So yeah, so eventually I wanted to say that this combining multiple techniques and getting underexplored biomarkers can lead to better characterization, and now even LLMs are being used along with the visual models to create more of a VLM setup to provide more accurate reporting, as we are not there yet, long way to go, but there are methods developed to at least characterize the lesions and also write a few keywords about it from the bag of words, the internet of things like that, which is quite useful. And also we are moving in the right direction of reporting, but as I said, it's a long way to go and requires a lot of feedback and also a lot of evaluation process from the clinicians as well. So, with that, I would like to finish my talk, and I would like to thank my funders for enabling my research, and my group, and also my collaborators for enabling my research. And again, thanks for the opportunity to present my work. And I would be happy to take any questions if you have. Thank you.
Thank you. Thank you, Dr. Vaanathi. Now the floor is open for questions if anybody has any.